সুপ্রিয় চিকিৎসক মণ্ডলী, আপনাদের সবাইকে আজকের ওয়ার্ল্ড পিসিওএস অ্যাওয়ারনেস মান্থ উপলক্ষে আয়োজিত অত্যন্ত গুরুত্বপূর্ণ একটি ওয়েবিনারে স্বাগতম। আপনারা ইতিমধ্যে জানেন আমাদের আজকের টপিক ওভারভিউ অফ পিসিওএস। এটা আসলে সারা পৃথিবীর সাথে সাথে বাংলাদেশেও আজকালকে পিসিওএস এর প্রকোপ অত্যন্ত বেড়ে গিয়েছে। আপনারা আজকের সায়েন্টিফিক সেশনে এই সম্বন্ধে ডিসকাশন শুনবেন এবং এই সেশনটি আয়োজনে যথারীতি আমরা বিডি ফিজিশিয়ানস এবং আমাদের সাথে সায়েন্টিফিক পার্টনার হিসেবে যুক্ত আছেন রেনেটা পিএলসি এবং মডারেটর হিসেবে আছি আমি ডক্টর এসামুজ্জামান খান, অ্যাডমিন বিডি ফিজিশিয়ানস। এবং আমরা অত্যন্ত লাকি যে এই টপিকটি নিয়ে কথা বলার জন্য আমাদের মাঝে আজকে আছেন আমাদের সবার পরিচিত এবং অত্যন্ত শ্রদ্ধেয় প্রফেসর ডক্টর শেখ জিনাতারা নাসরিন ম্যাডাম। ম্যাডাম আমাদের গাইনিওপস জগতের একজন লিভিং লিজেন্ড। আপনারা সবাই ম্যাডামকে চিনেন। আমি জাস্ট একটু ম্যাডাম সম্বন্ধে একটু বলে নেই। ম্যাডাম ইজ ওয়ার্কিং অ্যাজ প্রফেসর অফ অবস গাইনি, জয়নুল শিকদার মেডিকেল কলেজ অ্যান্ড হসপিটাল। ম্যাডাম চেয়ার সিএমই কমিটি ওজিএসবি। ম্যাডাম অর্গানাইজিং সেক্রেটারি বিপিএস বাংলাদেশ পেরিনেটাল সোসাইটি। এবং এর সাথে ম্যাডাম মেম্বার সেক্রেটারি অফ সিপিডি কমিটি অফ বিসিপিএস, সায়েন্টিফিক সেক্রেটারি অফ জাস্টিস চ্যাপ্টার বাংলাদেশ। এবং ম্যাডাম এছাড়া বিভিন্ন টেক্সট বুকের অথর হিসেবে ম্যাডাম কাজ করছেন। ম্যাডাম হ্যাড মোর দেন 50 পাবলিকেশনস। আমরা অত্যন্ত অনার্ড এবং এরকম একটা গুরুত্বপূর্ণ টপিকে আজকে ম্যাডামকে স্পিকার হিসেবে পেয়ে। এবং আমাদের সাথে আজকে চেয়ারপারসন হিসেবে যুক্ত হয়েছেন আমাদের সবার অত্যন্ত পছন্দের এবং বিডি ফিজিশিয়ানস একজন হিউজ ওয়েল উইশার ডক্টর ফারিয়া আফসানা। ম্যাডাম ইজ ওয়ার্কিং অ্যাজ অ্যাসোসিয়েট প্রফেসর অ্যান্ড হেড অফ দ্য ডিপার্টমেন্ট এন্ডোক্রাইনোলজি বার্ডেন এবং ম্যাডাম প্রেসিডেন্ট ইলেক্ট বাংলাদেশ এন্ডোক্রাইন সোসাইটি। উইদাউট ডুইং ফার্দার ডিলে আমি আমাদের আজকে সম্মানিত চেয়ারপারসন ডক্টর ফারিয়া আফসানা ম্যাডামকে বিনীত অনুরোধ জানাচ্ছি সেশনটি আহ্বান করার জন্য।
ধন্যবাদ। ধন্যবাদ ডক্টর এহসান খান এবং ধন্যবাদ বিডি ফিজিশিয়ানকে এই সময় উপযোগী টপিকটা নিয়ে আজকের এই ডিসকাশনের প্রোগ্রামটা অর্গানাইজ করার জন্য। আজকে আমরা শুনলাম যে এটা সেপ্টেম্বর মাস এবং সেপ্টেম্বর মাস হচ্ছে পলিসিস্টিক ওভারি সিনড্রোমের অ্যাওয়ারনেস এর মান্থ। এই উপলক্ষে অলমোস্ট প্রতিদিনই আমরা এন্ডোক্রাইন সোসাইটি, অবস্টেট্রিক গাইনোকোলজিক্যাল সোসাইটি বিভিন্ন প্রোগ্রাম অর্গানাইজ করছি। তো তারই সূত্র ধরে আজকের এই প্রোগ্রামটা আশা করি অডিয়েন্সের জন্য খুবই হেল্পফুল হবে এবং আমাদের সকলের প্রিয় স্পিকার আজকে আছেন আমাদের সাথে। আমি আহ্বান জানাচ্ছি আমাদের প্রিয় ম্যাডাম শেখ জিনাতারা নাসরিন ম্যাডামকে তার প্রেজেন্টেশন শুরু করার জন্য।
Honorable Chairperson, Honorable Moderator, and all the participants of BD Physician, Assalamu alaikum and very good evening. Can you hear me?
জি
Yes,
ম্যাডাম,
madam.
শোনা যাচ্ছে।
Okay, fine. So polycystic ovarian syndrome is very common. It is a heterogeneous and most common endocrine disorder. It is associated with hyperandrogenism and chronic anovulation, but there's no underlying specific pathology or other causes. And not necessarily that this condition should have polycystic ovaries by ultrasonogram. Next. So, but we know that PCOS is a very common disease in Bangladesh and all over the world. But unfortunately, 70% of cases remain undiagnosed. Next. And this is Awareness Month. I mean, September is the Polycystic Ovarian Disease Awareness Month, because if we are not aware, how can the disease will be known? That is why 70% remain undiagnosed. So the important thing that we have to create awareness to, because it is often missed, often misunderstood, and it affects the long-term consequences like fertility, metabolism, mental health, and so on. And there are a lot of myths and stigma, and these actually keep the women refrain from getting the right support. But awareness bring earliest diagnosis, earliest interference with the holistic care, and improve the quality of life. If we look at the prevalence, the prevalence all over the world almost same. It has been said by the FIGO and WHO that 6 to 13% of young adult women are affected by polycystic ovarian disease or syndrome. And again, very surprisingly, 11% of adolescent girls are also being affected. And this PCOS prevalence is very high in case of obese women and, of course, in infertility women. So, PCOS is a significant public health. It is a significant public health and it is a challenge, public health challenge all over the world because it is not only the single disease entity, it is a syndrome affecting all the systems of the body like dermatological status, psychological status, cardiometabolic syndrome, reproductive health, as well as endocrine health. Therefore, to understand better PCOS, we have to go to the root level of the pathophysiology. But again, the pathophysiology of PCOS is still uncertain, although evidences are saying probably there is a genetic predisposition, endocrine and environmental factors are related to that. So, better understanding is telling us there's interlocking dysfunction. Next, please. Next, please. Yeah. What is those? I mean, genetic, epigenetics, environmental factors are most important pathogenesis. And that probably results hyperandrogenism and dysfunction of the ovarian pituitary axis. And not only that, it has been also says that the prenatal intrauterine exposure to follicular microenvironment after birth and the postnatal lifestyle has a great effect. And endoplasmic reticular stress in the ovarian follicle are also responsible for the PCOS syndrome. And very latestly, we know that gut microbiome alteration, and especially before the puberty, has tremendous effect in the pathogenesis of PCOS. So, how is our understanding? Though in the literature search, it has been seen that it has been told in the literature back in 1848 by the Harvard endocrinologist, and thereafter the Steen-Leventhal syndrome. Can you show the picture of Steen and Leventhal? Yeah, these two scientists, they have given us full-blown pictures of the PCOS back in 1935. Since then, a lot of research is going on, and now we came to understand, which has been updated in 2018. Next, please. And 2023, the Monash University guideline evolving through the 5 years and gave us a concrete evidence-based data. And we understood the main culprit for the pathogenesis are the hyperandrogenism, altered gonadotropins, and the recently targeted genes. Insulin resistance is the most important. Insulin resistance, can you show the next slide, please? Because insulin resistance is the pathogenesis and the main key of PCOS, and which actually producing all the symptoms of PCOS women, starting from hirsutism, hyperandrogenism, also late onset diseases. Next, please. This picture is very interesting. No, you see there is a genetic predisposition which is acting directly over the ovary. Also, the environmental factors, they are influencing the ovary to produce more and more testosterone, we can see. And this testosterone inhibits pituitary gland to produce FSH. And there's a high LH, and this results into anevolution. Also, anevolution and testosterone both together causes insulin resistance and thereby producing hirsutism and reduced sex hormone binding globulin. As the sex hormone binding globulin in the blood is very low, so androgens are freely circulating in the blood and producing all the symptoms. Therefore, if we want to diagnose the most importantly, still we are following the Rotterdam criteria, which was set up during 2003 by different consensus together. That is, there will be oligoanevolution or oligoanevolution that leads amenorrhea, oligomenorrhea. One group. The other one is the hyperandrogenism. It could be, clinical feature or biochemical. And the third one is polycystic ovarian syndromes or polycystic ovaries, morphology in the ultrasonogram. So for young adult women, if two from any three are present, we can say, yes, she is suffering from polycystic PCOS. So the any two from these three will be the diagnostic criteria. But again, there is some controversy regarding the adolescent girl. Oh, yes, this is actually the morphology of the polycystic ovary, where though in the ultrasonogram we can see that the stroma of the ovary is very increased and the follicles, very small follicles from 10 to 20 are arranged at the periphery. But well, that is a very good picture of the polycystic morphology. But in case of adolescent, the concept is quite different. What is that? Well, when the young adolescent girls are coming with irregular period, just 1 year after the menarche, we should not jump to that, she's having polycystic ovarian disease. Rather, after 1 year, if she develops menstrual irregularities, like, she's not having period for 3 months, 4 months, 6 months, at least 3 months, 90 days interval, then she is having irregular period. Or she is not having a prolonged period, but she is having cycles for more than 45 days or less than 21 days. That is menstrual irregularities. So if adolescent girls, they come with this type of menstrual irregularities like prolonged period, prolonged absence of period, 3 months, 6 months, like that, and with the symptoms of hyperandrogenemia. I will just say very soon what are the symptoms of hyperandrogenemia. That lies, hirsutism, severe acne, obesity. These are the important criteria to diagnose PCOS in adolescence girl. Ultrasonogram? No, that is not recommended. At least within 8 years of the menarche. Young girls, their mother, they're coming to us and telling, doctor, I have got the PCOS, polycystic ovary. Is it PCOS? Actually, you have to assure, no, this is not a PCOS. Ultrasonogram is not very much recommended for you. And of course, AMH, we should not go for the young adolescents. But of course, the ultrasonogram and AMH is very important for the young adult women. Therefore, if we summarize the diagnostic criteria, well, the women, young adult women, they should have 2 among 3, like clinical features of hyperandrogenism and anevolution, chronic amenorrhea, polyamenorrhea, oligomenorrhea, and polycystic ovaries in the ultrasonogram. So any 2 from the 3. So now let us see how the women of PCOS, they present to us. Most of them come with obesity and irregular periods, infertility, and mental worries. These women and young girls, young adult women, they become very upset because of, they're getting too much fat and their body shape becomes androgenic. And also they can notice that they were before pear-shaped, but now all the fats are being deposited in the upper abdomen. It looks like an apple shape. That gives a tremendous mental stress to them. So their external features becomes apple-shaped from the pear-shaped, and they become obese. Is it possible for lean women to get PCOS? Yes, it's not necessary that all the PCOS will be obese. Yes, the most of the women, like 80% of the women or girls, they will have PCOS, but 20% PCOS may have normal BMI. But nevertheless, there in that case, probably we feel difficult to diagnose. But if you diagnose that they have got hyperandrogenism and they have got polycystic ovary, then they have to be under follow-up because all features are same except the BMI, and they have got all the risk factors like obese PCOS, like type 2 diabetes, cardiovascular disease, infarct, all those things. You see, these are the typical symptoms of hyperandrogenism with insulin resistance. The blackening of the neck, you can see, young girls or young women, adult women are coming with the blackening in the neck region, in the cheek, in the neck, and sometimes below the breast. And that is known as acanthosis nigricans. They will come with the hirsutism. Hirsutism, though there's a mild hypersutism we can ignore, but if the modified Ferryman's Galloway score is above 6, definitely you have to take that she is having hyperandrogenism, no doubt. They might come with acne, pimples, and they might come with the baldness, alopecia, and oily skin. Also, some women, they're coming with the psychological disturbance. And many studies have found that the prevalence of mental health disorder, such as depression, anxiety, bipolar disorder, eating disorder, are very much common in the girls, women of PCOS. So this is also very important. Therefore, when women are coming to us, we have to take detailed PCOS history. And at the same time, back of our mind, we have to keep the differential diagnosis, that whether we are dealing really with the PCOS or the differential diagnosis I just tell now. So we have to get the past medical history, present medical history, any surgical history, endocrine functions history, family history. And the family history is very important. I have already mentioned the pathogenesis. The genetic predisposition is very high. Like mom, they have got the daughter, the same if they have the PCOS, auntie, the siblings, the sisters. So this is very important that it runs through the family and family. And also, we need to ask about the food habit, whether she's getting fat because of her bad food habit or actually she's having PCOS. So, history of sleep pattern is very important. We have seen that the stress, particularly stress in the reticulum, endoplasmic reticulum in the ovarian follicle, they produce PCOS. So, sleep pattern is very important to know. And PCOS, you need to know whether she's sedentary or doing exercise or not. This all can give the direction when we are planning the treatment also. Examination, definitely you have to go for the clinical examination. We need to look at the general examination, how the BMI, length and weight we have to measure, and we have to see the waist circumference or abdominal girth per abdominal examination. Particularly women who are coming with infertility, paravaginal examination is very important, which can give a lot of information. Investigation, yes, we have to go for the endocrine workup, starting from thyroid, LH, FSH, prolactin, free testosterone, androgen index, and androstenedione, dihydroepiandrosterone, 17-alpha, hydroxyprogesterone, sex hormone binding globulin, and also fasting insulin if we see that there's a insulin resistance evidences. One thing is very important. If we find the women are very obese, BMI is very high, more than 25, 30, then we have to go for glucose tolerance, OGTT, fasting blood sugar, hemoglobin A1C, and that has been, evidence-based. And of course, we'll go for the ultrasonogram. And at the same time, all the testing will help us to exclude whether she's suffering from Cushing syndrome, any androgen producing tumor, hypogonadotropin hypergonadism, thyroid disorder, hyperprolactinemia, or congenital adrenal hyperplasia. So that should be excluded. And then only we can say, yes, these girls or these women are suffering from PCOS. So why it is so important? Not only the presenting symptoms, it has long-term complications. Metabolic health risks, there's the metabolic syndrome. It has been seen that 30% of PCOS women may develop metabolic syndrome. And because of the insulin resistance, there's a dyslipidemia. She might develop diabetes type 2, cardiovascular disease, obstructive apnea, NASH, non-alcoholic liver cirrhosis, and of course infertility. We know that 30 to 70% of infertile women, they're having PCOS. And not only that, there's a pregnancy complications if they even conceive. And I already mentioned psychological derangement, so psychosexual problem, and eating disorder, and long-term cancer like endometrial cancer. And for the pregnant lady, we have to keep in our mind, if PCOS luckily get pregnant, then there's an increased risk of miscarriage, preterm birth, hypertensive disorder pregnancy, diabetes in pregnancy, hidden IUGR. So while we are treating these women, we have to keep all in our mind, and we have to be very meticulous. Now, if we go for treatment, well, so the important is very important is meticulous history taking, examination and investigation. Definitely exclude any diseases. PCOS is actually lifelong disease, and it cannot be cured, but the symptoms can be managed, and treatment is primarily directed at the major clinical manifestation for what she come for. I mean, whether she's suffering from anovulation, irregular period, or cutaneous hyperandrogenism, or for obesity, or for infertility. Whatever the treatment is, the counseling is very important, and holistic approach are required involving the PCOS education. Women has to have women, any girl or any woman, she has to have PCOS education, lifestyle modification. There are some pharmacological therapy. Of course, there's a laparoscopic ovarian drilling and other options too. So treatment will basically depend for what she comes for. So the treatment, the first treatment, lifestyle change. Lifestyle change is the bedrock of treatment because it goes a long way to prevent all the metabolic syndrome. And it has been seen that if we can reduce 5 to 10% of the weight for a PCOS women, then it may reduce insulin resistance, improves the ovulatory cycle, and there could be spontaneous menstruation. But this is a very tough job, particularly for young women, adolescent women, because I mean, the great motivation is required, and there should be a smart goal. I mean, just to say you reduce the 10% weight is not easy, and that weight reduction they should have a specific, measurable, achievable, rational, and time-framed goal to reduce the weight. We should take the help of, I mean, a gym, dietitian. I think it is a multi-professional task also. Diet should include, I mean, if you literature search even, you see there's no ideal diet for PCOS women. But we know in our perspective, you just look at the girls, if we can take more fruits, vegetables, and fibrous fruits, less carb, less sweet, sugar, I mean, that can help a lot. So our Bangladeshi food is good enough. But the important thing that women and girls, they should avoid the junk food like pizza, fries, burger, all those oily foods. But it is very difficult to say the girls. So what we should do, I mean, make them understand that you have to reduce your weight. So take the ideal food. Mom is cooking for 5-6 days, and only one day you can have your desired dish. Then weight reduction. I already mentioned that who are obese, more than 25, 30, BMI, they have to have reduced their weight. Exercise, it has been recommended that 150 minutes moderate exercise is recommended for all the PCOS women in a week. But if they're quite obese, 75 minutes or more vigorous intensities exercise is needed in a week, depending upon the weight. And it's very important to do the muscle straining because the PCOS women, they develop metabolic syndrome. So their muscles are full of fat. So muscle strengthening activities, at least in 2 non-consecutive days in a week, they should perform. So this is very important. Now let us come with the anovulation and irregular period. If the patient comes, or adolescents, girls are coming with the irregular period, that can be managed by oral contraceptive pill, of course the low dose, if she doesn't desire for pregnancy. Oral contraceptive pill is the first line choice for the irregular period. And we can give some progestin, that is also helpful. The important message is that women should not have oligomenorrhea more than 3 months because that has deleterious effect on the endometrium. So even if she doesn't want to have period every day, or she is not willing to take the OCP, especially young girls with their mom, in that case we can shed off the period at every 3 months. But if somebody, young women who are in the career oriented, or they don't planning to have baby now, OCP is the best. And another thing, the OCP not only reduces the 5-alpha reductase, it reduces the ovarian androgen. That androgen is the most culprit, and it increases the sex hormone binding globulin. So globulin catch all the androgen and reduces the androgen milieu in the blood circulation. So there's improvement of hyperandrogenism like hirsutism, acne, pimples, so on. But again, one important message is that while we are choosing oral contraceptive pill, we have to be very meticulous for choosing the progesterone, because we know that first generation progesterone, second generation progesterone like norethindrone, norgestrel, they are androgenic. So we have to avoid those progesterone. Rather, we have to choose the third, fourth generation of progesterone, which are non-androgenic, like drospirenone, microgest, cypriodone acetate. Cypriodone acetate is also anti-androgen. And if, like we use the Gyan 35 in Bangladesh, that is estrogen plus cypriodone acetate, is a wonderful drug to regularize the period, as well as it improves the acne, hirsutism. Well, now if we can manage the abnormal bleeding, now we have to go for the hyperandrogenism. What are the hyperandrogenism symptoms? Mainly the hirsutism, alopecia. These are the most troublesome symptoms. So hirsutism may be treated, physically, like removal of the hair, by cosmetic treatment, electrolysis, shaving, waxing, threading, and the cream is coming up, that is eflornithine, and most promising is the laser. So that is one option. At the same time, when all OCP is not working, the women or patients are getting more and more hirsutism, and OCP was used for 6 months, even she's not responding, only then we can start the anti-androgen. There are a lot of anti-androgens. Most popularly, cypriodone acetate I have just mentioned, but sometimes what happens, the Gyan 35 is containing very small amount of cypriodone acetate, so it may not improve the hirsutism. Then we have to increase the dose, or we have to choose other hyperandrogenism drugs like spironolactone, flutamide, finasteride. Among them, spironolactone is most popular. But when we are giving for long time, we have to also keep eyes on hyperkalemia. So it is very important. And flutamide and finasteride actually we don't use much because of their side effects. So cypriodone acetate and spironolactone is the most important drug for the hyperandrogenism. And next is the metabolic syndrome. That is the most culprit I have already mentioned. So for metabolic aspirin, metformin is the drug of choice, no doubt. It has been well evidenced. The dose usually 1 to 2.5 gram. It has to be given in divided dose, starting from lower dose and we can increase. And it has been proved that metformin reduces the insulin resistance and also it prevents the endometrial hyperplasia. And Cochrane database systemic review article showed that metformin is superior and effective than placebo with an additional ratio 3.9. So it is the first line agents when we feel appropriate in PCOS women for management of the metabolic feature. Of course, lifestyle change has to be along with the metformin and also for the OCP. Inositol is a very promising drug is coming up, and that is has particularly the women who are trying for pregnancy. Inositol is very promising drugs. Weight reduction, I have mentioned that 5 to 10% weight has to be reduced so that it will improve the physical and hyperandrogenism. There are Orlistat, there's a GLP-1 inhibitors, there's a bariatric surgery. So all are meant for the weight reduction, but lifestyle modification is the best one. But nowadays we are using Orlistat is being used for since many years, and it is being recommended. GLP-1 is inhibitors are coming up, and it is working really good. But there's no evidence till now that it is being used for the betterment for the adolescent PCOS. So we need to be very careful. I mean, when we are prescribing, we have to look at the adolescent. Yes, if she is very fat, very obese, that is a different issue. But we have to be very careful in counseling as well as prescribing the drug. Bariatric surgery, in our country, it's not that being popular, but in Western country, it's getting popular. But bariatric surgery, the problem is that it has a lot of side effect, and also they need structured weight management. It's not that they have done the bariatric surgery and their weight is reduced, so it's over. It is a lifetime. It's not that. They also need a structured weight management program involving the diet, physical activity, and intervention and cardiovascular health to be continued post-operatively. Infertility, I'm not going to discuss details about the infertility because that will take another 1 hour. So just one thing is important that with treatment, most of the PCOS women, they're able to get pregnant. So if somebody is coming to us, we can treat her and there's a good outcome. So you can assure them that yes, there is a treatment. Most first line treatment is the ovulation induction with the letrozole. That is a very helpful and that has a very good outcome. And ovulation induction is a very important part we can use for at least 6 months. There's no doubt with all this precaution, you can go for the ovulation induction for 6 months. And then you can think about whether you should refer to the infertility specialist or you can go for the laparoscopic ovarian drilling. Laparoscopic ovarian drilling has been chosen as a second line therapy for women, particularly when with the anovulatory infertility. And there's no other infertility factors. When we are dealing the infertile women, we have to work off to look at that. Is it only PCOS or other factors are responsible for the infertility? So laparoscopic ovarian drilling is individual choice. We can see, we can do that. That ovarian drilling actually reduces the androgen bulk from the ovary. So that is also very helpful. Fail that after induction of ovulation by the letrozole and we did the laparoscopic ovarian drilling, but still patient is not responding 1 year, 2 years, depending upon the patient's age and MH. We have to refer to the dedicated infertility clinic, and they have very good opportunity to offer artificial reproductive technique or ART. But one thing is important. Even with us, even with the ART, even with the medical treatment and the lifestyle change, ongoing psychological support is very important, not only for infertility, for our external feature, psychosexual derangement. They badly need, psychosexual or psychological support. If necessary, we need a multidisciplinary team approach. Well, September is a PCOS. I am just going to end my topic. It is September. This month is PCOS Awareness Month. Let us all raise our voice let us know how to diagnose, and no women should left behind, so that we can go ahead. And PCOS is long-term condition with wide-ranging feature beyond only reproductive health. PCOS pregnancy is high risk, so we need a special care for them. PCOS raises the risk of diabetes, heart disease, long term, so many things. So they need lifelong follow up. And last but not least, mental health is very important. If mental health is not good, women cannot survive. So, with physical health support, we all need to extend our hand to boost up their mental health by all kind of support. So I'd like to conclude by saying that PCOS is a common endocrine disorder for young adult women, but not the adolescent and menopause women are immune. They're also affected by PCOS. It begins from childhood, start as obesity, continue as a menstrual disorder, infertility, pregnancy complication, and various chronic disease like diabetes, hypertension, cardiovascular disease, and endometrial cancer. Therefore, it looks like a public health problem. Early interference, early diagnosis, lifestyle modification, and counseling for weight reduction is the key for prevention of long-term comorbidities. Psychological stress of PCOS is tremendous, so we need to address this issue also with the holistic management approach, and that improves both the mental and physical health of the PCOS warriors. Thank you very much for the kind attention. Thank you very much.
Thank you very much for this wonderful presentation. আপনি এই অল্প সময়ের মধ্যে পুরো পিসিওএস এভরিথিং কভার করছেন ম্যাডাম, থ্যাংক ইউ ভেরি মাচ।